as they want, but I just want to say hi to everybody, even though I can't see your faces. Hopefully sometime soon we'll all get to meet in person. But for those of you who don't know who I am, I'm Greg Griffin with Crawford Evaluation Group. So I want to thank you for having us today to do this presentation on medical toxicology and drug testing that you guys see so often in some of your claims. So I just wanted to say everyone should be automatically muted when you come in. If you have any questions, you can use the chat feature at the bottom of your screen, or you can unmute yourself to ask any questions. Dr. Tovar is going to be the first speaker today. Dr. Richard Tovar, he's a board certified specialist in emergency medicine, medical toxicology, and addiction medicine. He's a former sworn law enforcement officer in the state of Wisconsin and has testified numerous times as an expert in cases involving people under the influence and the use of alcohol and or drugs. So he's quite the expert and knowledgeable in this area. Following Dr. Tovar, you'll hear a legal perspective from attorney Sean Spencer with Spencer Law. He's a work comp defense attorney in Wisconsin. So just to kind of follow up or answer any legal pointed questions that you may have. I've got this slated to go for an hour and a half, but I am recording it, so feel free to leave for whatever purposes you need at any time, and the recording will be provided to you to catch up some other times if you choose. So with that, I'll let Dr. Tovar take over the host, and if you want to share your screen to get the PowerPoint going.
Awesome. Thank you all very much for letting me talk to you on a beautiful summer day. As was previously stated, please, you can go ahead and unmute yourself and ask a question, or you can use the chat box. And so what I'm going to talk about today basically is basically an update on what I like to call insurance toxicology. And let's see here. If we do next slide here, it's not doing that. Oh, here we go. Nope. It's not responding, so we're gonna have to figure something out here.
I think you want to hit the play button up at the top.
Okay, there we go. All righty. So I'm going to let you all know things have changed, obviously, from the last time I gave this talk. And I'll let you know that, as you heard in the intro, I'm a physician. So this isn't legal advice, but unfortunately, a lot of this stuff is what we call forensic medicine, which is kind of a combination of legal type issues and then medical type issues. And it's not medical advice either. And it wouldn't be, because this is really mostly about testing and observation. And it really is a perspective on drug testing in the workplace from a medical toxicologist, MRO, which is a medical review officer. And I'll go into what that is, but most states and the federal government have created what we call a backstop, or an intermediate person that supposedly objectively reviews the drug tests as a medical provider and decides whether or not the story in a positive drug test is believable or not believable. And the medical aspect of it is from SHMSA.gov. If you want to take a look at it, there's a lot of stuff there, but it does have some reviews of what we're going to talk about. So speaking of, when the donor gives a urine drug specimen or other tissues such as hair or saliva at the testing site, the specimen goes to the lab, and it's a forensic lab, and they usually have to be certified by their certifying bodies. And then if it's positive, it ends up going to a medical review officer, and they work for various and sundry type situations. They may work for the hospital, they may work for themselves, they may work for a big group, those types of stuff. And they are supposed to certify the results. And usually when there's a positive, there is an attempt to contact the donor to have them explain the positive. One of the things that is not required is that when the donor gets to the donor site, they're not supposed to tell the people who take the drug test what medications they're on. A lot of times when I talk to these folks, well, I told the person who took my test that I was on XYZ type drugs, and I explain to them they can't take, all they're there to do is make sure that the drug test is obtained in a chain of evidence in a legal manner that can be viewed. It has nothing to do with their medications. So they might also tell you that too. I told them I was on X. By federal regulations, the physician, and in some case, physician assistant or nurse practitioner in other states, but not in Wisconsin, is required to take and pass a test for the interpretation of the drug test. The science isn't the tough part. It's the federal law and those types of things, the state law that pertains to the positive drugs. And then we're supposed to communicate with the donor. And after that, we communicate with the workplace representative when the test is positive and let them know. So what I wanted to do is just basically go over a few quick cases and add some things that weren't added before. And you'll see why, because there's a new drug that we all know it's on the horizon that's making things very interesting in the insurance and medical toxicology industry. And basically, so there were two people in a warehouse incident where one employee number one runs his forklift into the second employee on a ladder. And they're both injured and taken to the hospital by the emergency medical people. And the first one, he hit his head on an unknown solid object and he's dazed. And the second one fell from a height of approximately 6 feet onto a concrete floor and injured his pelvis, back, and hip. The first person in the emergency department, the forklift driver, had these medications in his on his medication list. Adderall, which is for it's a speed type drug related to amphetamine for ADD disorder, basically to help you concentrate more. Painkiller called oxycodone, what most of us know about. Another medication for nerve pain, gabapentin. Lasix is a diuretic for blood pressure problems. And then the second person had supposedly sertraline, which is an antidepressant, and he was on a fentanyl patch. So that is a patch that goes on your arm or your leg or your chest for pain control also. Nothing else is known about these folks, and their drug screens basically are the following. The forklift driver has oxycodone in his system, he has gabapentin in his system, and he has Adderall in his system. The second one has codeine, morphine, alprazolam, fentanyl, and THC, has marijuana in his system. And that's where we're going. As we all know, there's been a sea change of how people view marijuana over the last several years. And a lot of folks, especially young folks, but in my clinical practice of emergency medicine, all ages look at it as something that is helping with pain control and anxiety, and it's been touted as a lot of things. Now, I'm going to tell you, surprisingly enough, medicine hasn't caught up to that. There isn't really a whole lot of good proof that marijuana does all these things people say it does. And the same thing goes for CBD, cannabidiol, CBD oil. So right now, even though we've been studying marijuana effects for over 50 years, the actual claims that people make about the health positive effects have not been borne out yet, but people believe it anyway. And as you well know, there's several states that have both medical and recreational allowance by the state law for people to use it, and therefore they show up to work with it. So basically, a person who needs a drug test, we can use their blood, serum, and I'll tell you the difference between those two: hair, saliva, stool. We could use all kinds of things to basically test them for the presence of a drug in their system. Blood toxicology results are actually different. It's interesting, and I've never been able to find out why, but in forensic testing, such as a driving under the influence, the states use blood alcohol, whereas in the hospital, if you come in and you fall off a ladder and we draw your alcohol level in the hospital, we use serum alcohol, and I'll show you the difference. There's at the bottom, there's a way that you can convert blood alcohol to serum alcohol. And there's also breath alcohol, but in my forensic practice, we don't use a lot of that because breath alcohol is not looked upon in the forensic world to be accurate. However, in the occupational world, it is looked upon to be accurate. But it's challenged, breath testing is challenged a lot more by folks who test positive. It's a new trend. We're seeing it a lot more. So what is a blood ethanol? You can see by the tube here that really the blood is white right at the bottom. It has a lot more solid components to your blood, your red blood cells and your white blood cells, than the plasma or the serum, which is more liquidy. And therefore, you can imagine that there'll be more ethanol or alcohol in somebody's plasma than there will be in their blood. But if somebody gets a blood test in the hospital, they're going to get the plasma, which is the same thing as the serum. And if they get it in the police station or in a criminal type of an issue, they're going to get the blood ethanol test, just to let you know the difference. And mostly in the occupational world, it's a breath test. As we know, that the DOT, the leading federal agency that wants to test people at work for either post-accident testing or for pre-employment testing, they are trying not to be invasive, and therefore blood testing isn't done. That's seen as invasive, sticking a needle in you, whereas peeing into a cup or clipping some hair off close to your scalp is not seen as invasive. So there's two types of drug tests, and that's another thing we have to be careful of when the donor is giving a specimen such as urine. The first one is a drug screen, and all it does is test for general drug classes. And a good example of that is the stuff you can buy at Walgreens. You can pee into a cup and test it real quick, or at the hospital or at the occupational clinic office, they can put a dipstick in the urine and they can get a test result right back. The problem with that is they are not as sensitive and reliable. So what you all know you're going to get is what we call a confirmatory test. So I've seen it happen where somebody is tested positive for example, an opiate on a drug screen right in the office, and then they send it off and it comes back negative, or vice versa, because the confirmatory test goes to these big forensic labs and is tested by these very specific machines, and they're much more accurate than just a dipstick in the urine. So what I act on is the second way to test it. That's a confirmatory test. I will not act on a drug screen, because for some drugs you have too many false positives and for others too many false negatives. So we use the confirmatory drug screen, and that's what you're going to see, just to make sure what we're going to act upon, what we're going to tell the employer about. And again, we talked about how forensic labs use whole blood, and we use plasma type blood or serum type blood. Interestingly enough, if somebody gets a medical urine test in the hospital, let's say they fall off a ladder at work, and we get a drug test that is medical, it is all we get in the hospital is a screening test. And you can well imagine, therefore, I caution emergency physicians and other clinical providers not to hang their hat on a diagnosis with a screening test. The good news is that for an occupational test, that urine then goes through the chain of evidence into the lab and gets tested as a confirmatory test. So when you're looking at hospital testing, it's always screening tests for the urine, and they are not as accurate as what you're going to get after that urine is sent to a lab and they get the confirmatory test. And you've probably heard of these big machines called gas chromatographs and mass spectrographs and stuff like that. That's what they test for. Usually in the hospital, the screening test is just kind of a dipstick, a color type thing. So want to warn you, just check when somebody says they were positive, make sure they had a confirmatory test. Okay, here's just a chain of custody record that you're all used to make sure it was done, and our attorney colleague will go over those, but I look at it to make sure that the boxes are checked off correctly. Okay, and the interesting thing about workplace drug testing is that we'll get into is that since there is no blood testing, the urine confirmatory test is something that we act off of as medical doctors and as people who and as companies who hire these folks. We're going to talk about cutoff levels, and we'll get into those also. Okay, so what a cutoff level is just when you can detect the drug. So if you have, for example, marijuana a week ago, and we test you today, you may not see marijuana in the urine. Although if you're a heavy user, marijuana is the worst drug because it stays in our fat cells for weeks to months, and it can still be detected. Unlike heroin, for example, which is out of your system in a matter of hours to a day. So what the federal government has decided to do for workplace is say, we're going to have cutoff levels. There's going to be a certain level of fentanyl, a certain level of marijuana, that below it, even if the machine can detect it, we're not going to report it out. For example, for marijuana, it's 50. So if you have 49 in your urine, they're going to report that test out as negative. Okay, and so that's for a lot of reasons we'll go into in the end. You're thinking, why? Well, I'll just spoil some of it. I was in a room with 50 other people who were smoking marijuana except for me, and I must have tested positive because of that. So that's why we've developed cutoff levels. We'll talk about that. You've not anybody hasn't heard that before. So here's an example of the cutoff levels, and it's nanogram per milliliters. First off, just to remind you, this is a confirmatory test, not a screening test. And sometimes the lab will test for a metabolite of the drug, such as cocaine metabolite is benzyl ecgonine, just to let you know. And other times they'll just test for the drug itself, such as PCP or phencyclidine. Okay. So cutoff levels are used both medically and forensically, but they're really defined in the workplace much more than in the hospital for just regular illness, or forensically, for example, if the state is investigating a DUI, a driving under the influence test. It's confusing because those three cutoff levels in those three different scenarios can be different, but the one you're looking at is the one for work. Here's the problem with urine. As we all know, what bathes our brain is blood. The problem is urine doesn't bathe our brain, and therefore all that a urine test can tell you is recent exposure. That's all it can tell you. But and our legal consultant can get into this more, the federal government, for example, has the DOT, Department of Transportation, has defined it doesn't matter. If you're positive in your urine, you are therefore by the MRO judged to be positive on your drug test, even though medically it doesn't mean the same thing. What it means medically is you were exposed, but what it means for DOT is you're positive. Okay, and therefore I want to give you that understanding, even though as a toxicologist I know that physically all urine positive means is you were recently exposed. It does not mean that you were intoxicated or under the influence of that drug that that you're positive for in your urine. And it's the same medically for everything else too. But when people go and get checked out for they're on drug rehab programs and stuff like that, we understand that medically they've just been exposed to those drugs, but they may not be acting in their system at the time they gave the test. In other words, they were just exposed, but not intoxicated or affected by them. And so what I've been asked by businesses, well, whose cutoff levels do we use? I say, why don't you use the ones that the federal government uses for drug testing? Because then if you try to go lower or higher, you'll have to explain why and get legal counsel and all that type of stuff. And it's a little bit harder. So I find that a lot of businesses I deal with as a medical review officer usually use the federal cutoff levels. The problem with the federal testing is that they only test it. It used to be 5 drugs, but they've added oxycodone and hydrocodone. They only test for 7 drugs. What most businesses do now is basically get maybe a 10 or a 15 drug test. And those are extra drugs that are not found in the federal level. But if your protocol, if your workplace protocol for drug testing says we're going to do it, then you can go ahead and do it. There's a lot of businesses that go past the federal testing of only 7 drugs. They'll test for a lot more. So you can see here that the first, I would say 5 or 6 drugs can be federally tested for, but then we throw in methadone, which is making a big comeback. Methadone has been around for a long time for 2 indications in medicine, one for opiate use disorder and the other one for pain. And when I get somebody in the emergency department, I ask them, why are you on the methadone? I don't always assume they're on it because they have a drug use disorder problem. Some people are actually on it for pain, and they're not being prescribed it by a pain management doctor, but by maybe their family practice doctor for pain. And then you see these other things, tricyclic antidepressants, that's for depression. So again, we're talking, when it comes to urine, positive doesn't mean the subject was intoxicated or impaired, only that he was exposed. And then you have to define what that means in your own drug workplace manuals.
Dr. Tovar, I've got a question that was sent to me, and maybe you just answered it. I was reading it at the time. Sorry, but the question was, if someone's test comes back substantially higher than the cutoff, does that mean they were intoxicated at the time of the test?
Say, that's a great question. And so all it means, it was above the cutoff. The other thing that you cannot do is tell how intoxicated you are with the actual numbers that you're seeing on the urine drug test. All it means, it was in your system, because we all metabolize the drug at different speeds and we take different concentrations. As we all know, for example, Colorado every year has a contest to see who can grow the strongest pot, so and I think there's a big monetary reward for that. So it all depends on how much you take, when you took it, what the concentration of the drug was. The problem with when labs give you a number for urine, it doesn't mean anything. All it means is it above or below the cutoff level? That answer your question, you think?
Yes, I believe so. Thank you.
Yeah. So we talked about we're all in the confirmatory phase. You see this, a big old fancy machine says gas chromatograph, and they follow the chain of evidence and they decide what the cutoff levels are. And just as the converse of the question was just asked, yeah, you can have somebody that's in an accident at work and have a marijuana level of 49 and they're negative on the drug screen. So, but in the forensic world, they would be positive. So welcome to the drug 101 and all the things that happen out there. Okay. just stopped moving. Okay, we're frozen.
Okay.
I'm going to share and unshare this thing because it just stopped moving.
All right, technical difficulty. So we'll,
Yeah.
I'm not sure how to get your screen to not, can you go backwards and forwards or?
Okay, let me just see here. There we go.
All right, perfect.
I think I got scared from you. All right. So basically we have to reiterate, it only means recent exposure. And so when you have somebody that tests, why am I going all over this? Because when you have somebody test positive at work that's post-accident, which is the most common, they're going to challenge the test saying, well, it's urine. I could have been, I smoked marijuana. I took my Percocet 3 days ago, and I wasn't manifesting any type of behavior that was consistent with marijuana, cocaine, amphetamines. And that's how they'll say that. But I'm sure you'll hear in the next talk, the next lecture, that's too bad. If you define a urine positive as a positive, and then that company has to go on and do something about it, then you're covered. Okay. But you're going to hear, I want you to know, you're going to hear these arguments. I get hired by attorneys and clients that basically say, well, Dr. Tovar, isn't it true that this positive marijuana only means recent exposure? And so I say yes. So when they ask me as a doctor, as a physician, how do you define intoxication? Intoxication is a medical diagnosis, and you need two things. One is proof of the drug in somebody's system, and two, which we have here, and two, an observed behavior consistent with the drug. So obviously, if they're nodding off and they look to be staggering and they have slurred speech and they have a positive drug test, you can make a diagnosis of intoxication. The problem is that you could be wrong if you used urine. You have to use blood. But again, the federal guidelines take this into account, and they say, too bad, so sad. We are not going to do an invasive test like blood, but we're going to say if you're positive in your urine on a confirmatory test, you are therefore positive, and they define that as, you need to go to counseling or you need to be fired, et cetera, et cetera. It depends on what the employer decides it'll be. So my recommendation is the business drug testing policy should recommend the federal drug testing. In my opinion, as a physician MRO, it appears to me that it's more legally defensible, but I defer to my legal colleagues. All right. So therefore, essentially medically, urine confirmatory testing will not tell you impairment. It won't tell you, like the question before, the amount of drug taken, the frequency of its use, if the level is therapeutic for the subject, whether or not the subject has substance abuse. You can't tell anything like that from a urine. You can do it from blood, but it's very, very hard to do it from blood, but you can do it from blood. So only tells recent exposure, and that includes the number. So let's say with that question, the cutoff level is 50 for marijuana, 50 nanograms per mil, and the person comes in at 500, it only means exposure. I can't tell if that person has a marijuana use disorder problem or if they just got really strong pot before they smoked it.
Dr. Tovar, there's a question in the chat stating, from a medical standpoint, do you care about the number or merely just if it's above the cutoff to determine intoxication?
Great question, and the answer is the latter. The number doesn't tell you anything. All it does is says you're positive, and now we're going into whatever policy that business has for a positive test. Great question, and it's really hard. All of us here are used to them reporting numbers, and numbers really don't mean anything, especially for urine, other than if they're higher or lower than the cutoff level. Basically, you won't see a number lower than the cutoff level. All you'll see is negative. So back to that 49 number, all you'll see is negative. But if it's 50, And I'll digress. There was a 19-year-old college student. It's one of the fastest people in the world in running the 100-meter dash. And she tested positive for marijuana and in her urine. And she probably won't be able to run in the Olympics when they come up this summer. We're really the fall because they postponed it because of COVID. And she was barely over, from what I understand from the media reports, she was barely over 50. Tragedy. So you're not going to see blood obtained, though, in the occupational field. You'll see it done forensically. You'll see it done medically, because we can more tell, back to the question, we can more tell if you're intoxicated with a number in your blood than we can with respect in your urine. So what are we going to do with these folks? We know that the person driving the forklift was positive for amphetamines and opiates. And what do we see? We see amphetamines was the Adderall, and we see the opiates. So it's a good match. Again, if you use a federal drug screen, they don't test for gabapentin. And Lasix, you don't have to worry about it. It's a diuretic, and it's not supposed to cause any type of brain or neurological impairment. So as you can see here, the drug screen, now we're talking about the drug screen. What didn't it pick up? It didn't pick up the gabapentin because drug screens are not as sensitive. But when we got the urine confirmatory test, there we go. Okay, so in this case, there was a good match with a urine drug confirmatory test. Well, then we ask, was he impaired or intoxicated? We got to go to the company policy. We got to look at how he was acting before the crash, the accident, and we have to go to the company policy. Basically, I recommend that when you see a positive, then it's a positive, and you don't have to worry about determining whether there was an impairment or intoxication, because you're asking coworkers and foremen to be and bosses to be medical people, and that's hard. That really is hard. Although they can give you that history too. I'm sure all of you have basically seen post-accident reports by supervisors that say, yeah, in my opinion, he was acting very strangely. Okay. So what can the donor do once I call them up and say, are you on oxycodone? Do you have a legitimate prescription for all the drugs that you're positive on the confirmatory test? And if they say, no, I don't have a prescription for oxycodone, then I inform them that the test is positive, and the work representative we contacting to tell them how to proceed. I do all of the MROs do a lot of work for different companies, so we never say what a positive is going to mean. In some companies, it means immediate termination. In other companies, it means they'll give another chance and retest, and in a huge gamut of that type of stuff. But what the donor can request then, and I explained to them this, I have to give them this option. When they came into the drug testing site, they gave so much urine, usually it's about 60 milliliters. They split it up into 2 different cups and basically sealed them both. And both cups usually go to the testing lab of choice. Some hospitals will pick one lab over another, and vice versa. Same with doctors' offices or occupational medicine testing. Well, I informed the donor that the second lab, the B cup, which wasn't tested, could be sent to another forensic lab to see and test if the first A cup value was truly correct. Now, there was in the Kentucky Derby, there was a horse where that happened, and the owner basically sent the second cup. And now they even do it for horses, especially that's big money, racing horses. The second cup got sent to a second forensic lab, and from what I understand, it was still positive. But I informed the donor that you can request it to be sent, but who pays for it is a different story. usually I recommend in the policy of the business that they state who's going to pay for that. Usually most businesses I work with say, all right, the payment is the responsibility of the donor, not of the business. And I tell them the test can cost anywhere from $80 to $200, depending on where it's sent. So I let them, if they're directing that to happen, I'll call the employee representative and saying they're directing this be done, and then they'll follow the policy. I don't know if I've never seen a donor direct it to be sent to a certain lab, but I've only had a couple in the last 10 years that requested a second test. So we talked about blood, how it's better to determine intoxication because blood bathes your brain. And we know if we see cocaine in your blood, it's probably in your brain. But we know if we see cocaine in your urine, it may not be in your brain. It may just be in your bladder. Or it could be in your brain. We don't know. So we can't, as a physician, we can't make that call. So we've already talked about how it's split up. How are we doing on time?
We've got, yeah, you've got about 10 to 20 minutes, maybe.
Good. Okay. Well, then the MRO can basically explain to the employee representative, is it a good idea to take 2 drugs that are sedatives when you're operating heavy machinery? Well, it all depends. Again, if your policy states that person has to tell the job that they're doing this and that they have a physician note that says, for your work, excuse me, for your work description, I'm going to go ahead and say you can do this in written form, then you can do this. This type of problem that we see in medicine and insurance and in hospitals is there are a lot of people on sedative hypnotic drugs. Those are the drugs like opiates, oxycodone or gabapentin, which is related to Valium, that are on sedative hypnotics that are climbing on roofs, climbing on ladders, basically driving skid loaders. Now for DOT, that's not allowed, but for non-DOT jobs, I see it a lot. And sometimes they're combining other drugs. And one of the main things I'll see when somebody has an accident at the job site is another one of these drugs were added to the patient's drug list for example, they went to the emergency department or to their primary care doctor and they got another drug added, such as a sleep aid or a new kind of pain medicine for their pain. And of course, it has a bad effect. They get drowsy and they get into trouble at work with a fall or something like that. So again, I recommend that they have written documentation from a medical provider who's the prescriber that they can operate heavy machinery while taking these types of medications. And basically, we all know what happens when you take these things. It doesn't matter if you're driving a car and you get pulled over by the police, or if you're driving a skid loader at work. You know, when you have one sedative hypnotic, you're going to have the following issues, and you're going to multiply it after that. Now, believe it or not, if you're on oxycodone and gabapentin, when they act together, they don't double each other. They actually become synergistic, which means they act at different parts of the brain. And therefore, instead of seeing a doubling of the above symptoms, such as decreased alertness, poor balance, or drowsiness, you have an even greater than expected effect. So 1 + 1 equals not 2, but 1 + 1 equals 3. So you even have a bigger effect than you anticipated when you start to mix these drugs. So that's what happens when you take them acutely. But I've seen people who are driving and are on, for example, methadone for drug use disorder, who've been driving safely for years because they develop tolerance. And tolerance means basically you need higher doses of the drug to achieve the same effect. But really, how I look at it, we should look at it is when you take the methadone, you don't get high, you don't get sleepy, and you can perform your activities of daily living. Now, the problem comes in on the forensic side is when somebody runs a red light that's on methadone and hits a family of 4 and injures them. That the problem is, unfortunately, they're already on a drug that when they asked me, Dr. Tovar, is there any safe level of methadone, Valium, cocaine that you can operate heavy machinery on or that you can climb a ladder on? And there's not. Just like there's no safe level for ethanol for alcohol, but the per se level for driving a car is 0.08, which basically tells all of us if you're 0.07, you're not guilty, right? So, but that's the only drug we have that for. All the other drugs, there is no safe level. The problem is, again, when it comes to cutoff levels, you can be like with marijuana. Well, marijuana is illegal. Let's talk about hydrocodone. You could be under the cutoff level, but still have drug in your system, but be negative. Okay, so you can see that there's a lot of issues with this. But just to tell you that when you combine drugs, the chances of a bad effect are higher, statistically higher. And when you add other drugs that aren't even sedative hypnotics, that don't make you drowsy, such as antibiotics, such as medications for inflammation, such as blood thinners, you can affect the way the brain handles the drug, and you can have side effects. And that's what we try to warn people. Like, for example, if somebody comes in the ER and I start them on a non-sleepy type drug, but they're already on hydrocodone, I warn them not to drive for a few days until they're seeing how the drug affects them, because we don't know how it's really going to affect them. There's not, we call that idiosyncratic. That's a fancy word for, if I give you a drug and you're already on other drugs, you may have some effect, no effect, or a bad effect. And we don't know that for a few days. So we try to warn them, as does their family practitioner, as does their surgeon. You know, if you're on pain medications, be careful when we start you on something else. So again, we don't, and there's no way to predict who that's going to happen to. I wish there was, but if somebody's already on oxycodone and we give them a non-sedative hypnotic drug, they could have some effect, no effect, or a really heavy effect, but we don't know how that's going to be. And it's usually in the first day or two. What about now the subject number 2? There's, you see on the drug screen, now remember, drug screens are not as accurate as confirmatory screen. You see that the person is on benzodiazepines, which is a Valium type drug, but we don't see his sertraline and we don't see his fentanyl. What's going on with that? But we do see a marijuana. Well, the marijuana is easy. He's taking marijuana and he didn't list it as a medication. What happened to the fentanyl? The problem with fentanyl is most hospital drug screens don't test for fentanyl. And so that's okay, because if he has a confirmatory drug screen, they'll find the fentanyl, okay? But what happens if they don't find the fentanyl? Well, he's not taking it, right? And that's because he's either non-compliant or he's diverting it. So you'll need an MRO to get you through these types of things. There's so many things that'll happen, but I can tell you, just if somebody's on a painkiller and we get a confirmatory drug screen and we can't find it, either they're not taking it or they're selling it on the street. That's what diversion is. So there's a lot of nuances to all this. And again, this person, I see a lot of marijuana positives on confirmatory drug screens in people who are taking pain medicine for pain and also for drug use disorder, because the thought process is the marijuana enhances these drugs, enhances the fentanyl or the Valiums of the world. So we see a lot of multiple drug screens. We try not to use the word dirty drug screen. That's a negative. So I tell the patient, when I see the marijuana or other drugs they're not on, I call that an unexpected finding. And can you explain that to me? I think it's very negative to use the other word, the dirty and stuff like that. So there's a whole new way of explaining side effects in addiction medicine to people. And we just say you have an unexpected finding, sir. Tell me why that is, or madam. So this subject number 2 had codeine, morphine, alprazolam, which is a benzodiazepine like Valium, fentanyl. He had marijuana in there. And again, the numbers sometimes will be given. That was that question. But these drugs are all present because they went over the cutoff level. Okay. And so each one of these different drugs have a different cutoff level. So you, again, when you see numbers in the urine, you can't make any type of assertion that the person was intoxicated, that the person wasn't intoxicated, they were taking their medicines correctly. The only way you can do that is with blood. And the donor states, this is where we're going into THC. We've heard that, I call this the side stream defense. The donor states that he was passively exposed to the marijuana as the reason for positive THC. I see that a lot. Well, the federal government has done 3 studies so far, one in the 60s, one in the 70s, and then one in the 90s. Basically, they put people in a room, and you're going to love this. They put a single person in the room, and they started drawing their blood and getting their urine, and then they piped in or put in marijuana smoke into the room, and they tested that person at time 30 minutes, at time 1 hour, all the way out to like 6 or 7 hours. And they found that that person, all these subjects, which I think were medical students probably, all these subjects never got above a certain level. And none of them got above 50. There were some that got up to 7, 8, 15. And so they moved the level from that low level up to much higher. And so right now, if somebody has a positive THC marijuana on their urine confirmatory drug screen, we do not take passive smoke exposure as a reason to make it a negative. And that's all. And so this passive means secondhand smoke. And there's no study supporting at the levels we see now for marijuana on the confirmatory drug screen, a positive test for secondhand smoke. And again, we cannot opine, we cannot say that somebody was impaired medically, but you can say they were positive and define what positive is with respect to the employment policy. So here's the non-federal expanded tests. And then I always get asked, you know, the second defense we're going to talk about is what we call the poppy seed defense. Poppy seeds do contain codeine in very small amounts. And actually there are some people that can metabolize them or break them up, and you can see actually small amounts of codeine, which gets in turn metabolized into morphine and in somebody's system. And again, they did what they did the same way for marijuana that they're doing for poppy seeds. They raised the cutoff level very high. So again, they did studies and said, how many poppy seeds bagels do you need to eat that will cause you to test positive on a urine drug screen? And you have to do a lot because they set the bar really high. Every once in a while, I have a person who's read the internet that says, hey, I'm not on morphine, I'm not on codeine, but I do eat poppy seeds. The tough part comes when they're already on a doctor's for forensic, not for occupational, but they're already on a forensic, a morphine prescription or a codeine prescription, and it bumps them over from from the from the negative level to the cutoff, above the cutoff level. For occupational medicine, it doesn't matter. If you have a morphine prescription, if you have a codeine prescription from a provider, a medical provider, you're good to go. It doesn't matter if you got bumped up above the cutoff level, because you're covered. The problem is, and if you don't have a prescription, it doesn't matter either, because you can say it's poppy seeds, but again, we don't use that as a defense because we've set the cutoff level so high. So with this person, we know that the poppy seed defense didn't work because he was way over the cutoff level. And so that's the only time, going back to the first question, when levels mean anything, when you're above or below the cutoff level. But if the cutoff level for morphine, for example, is 100 nanograms per mil, and you're 99, you're going to be negative. And if you're 10,000, you're going to be positive. But again, I can't tell you if that person has an opiate use disorder, or is taking his morphine inappropriately, that kind of stuff. You can't make anything other than to say there's morphine in their system in a recent exposure. And here are all the cutoff levels. We were just talking about, marijuana, it's 50. And look, this drug is the most fat soluble drug of all these other drugs that are on this list. And you can see one of the defenses was, yeah, but I haven't used for a week. It's still, unfortunately, if you define a positive as a positive for occupational medicine in a confirmatory urine, it's still a positive. I tell the person on the phone I believe them, but it's up to the employer and their policy and what they call a positive and what they call a negative. And you can see, for example, right underneath methadone, which is it's only in your system 3 to 5 days. That's it. And the problem with that is, though, if you have chronic use, it'll be a little bit longer, but it's never a month like it is for marijuana. And the other thing is, you can smoke one joint of marijuana or have one exposure to marijuana and still have the marijuana in your system for a week to 10 days because it's so fat soluble. So you can well imagine, if you're taking methadone every day, it's going to stay in your system for a long time. But 3 to 5 days, maybe a week at the most, where if you're taking just a little bit of marijuana, it can stay in your system a week to 10 days because it's so fat soluble. That's the worst one. And it's obviously the most politically charged now, because people believe it should be looked upon as a medicine, not as a illicit drug. So we use back to the first question, there's only a few drugs we actually care about their true levels. And one of them is phenobarbital, for example. It is a anti-seizure drug. It's used for other stuff in the hospital. And we can get a really quick, rapid level of it to determine if the patient's toxic or not. And it's 15 to 40. But most drugs, they're all over the place. They're arranged, they overlap. And you have to also look at the patient to determine, along with the blood level, if they're intoxicated or not. So we're basically going to just reinforce the fact that you need blood or serum and an observed behavior to say you're impaired. You cannot do this with urine, and you definitely can't do it with a drug screen. Remember, a drug screen just tests for general classes. You have to have a confirmatory test before you tell the patient they're diverting or they're not taking their drug appropriately, that type of stuff. So the specimen of choice right now is urine, but you can again use hair and saliva. They have their issues also, but urine is still the most commonly used when you see a positive or negative drug screen. And just because the urine drug screen is negative, it doesn't mean that they don't have the drug in their system and that there was no exposure. But we have to what you've heard the reasons, such as the poppy seeds. We have to cut it off somewhere, and usually the cutoff levels are high, so that we don't make everybody who eats one poppy seed sandwich a positive. So just because on the forensic side their level is negative doesn't mean that they don't have it in their system. And again, you need blood and an observed behavior to determine if there's a medical intoxication. But that means nothing when it comes to what is a positive, what does the business define as a positive. So I'm going to stop here. I think we're a little bit early, but I'm going to entertain questions, and please unmute yourself, or I can't see the chat. So
I've got one question. There's one question in the chat, Dr. Tovar. If we have a critical care patient and blood is drawn, can he determine intoxication based on the blood results with no indication of physical symptoms?
That's a great question. And most of the time the answer is no. If that person was not seen, and I've seen that a lot, for example, somebody that falls off a roof and they end up in the ER, nobody saw them fall, basically, and they have an alcohol level that's elevated, it is, you can argue that you shouldn't be on a roof with a high alcohol level, but you can, and you can say there was a probability, but you cannot define it as intoxication. You can say basically that at this level of alcohol, this is what the general population does. They have poor coordination, they poor risk taking, that kind of stuff. So you don't have both, but you can pretty much, for alcohol, for example, make that determination. When it comes to every other drug, even if you get it in the blood, it's much more difficult. If you get an actual level of oxycodone, and you, for example, I'll ask the insurance agency, or I'll ask the business to get me the physician's or the medical provider's notes, and we'll look to see if there were any side effects. Because as I said before, if there weren't, and the medical provider giving them that type of drug, not alcohol, believe that there were no side effects, then it's much harder to prove.
All right, that looks like the last question on the chat. So, and again, everyone, if any questions come up later, you can email them to me, Greg Griffin, and I can get them to Dr. Tovar. But Dr. Tovar, thank you. If you want to stop sharing your screen and hand back, or I'll try to reclaim the host duties, and then I'll hand them over to Sean Spencer for the remaining time.
Let me see if, oh, wait a minute. Okay, there's one more in the chat. Did you clear that chat? Let me just see.
Yep.
Okay, good. All right. I'm trying to stop the share here. I'm just going to give it back to you.
Okay. Yeah, I just took it back. So.
Okay, good.
But I think you still need to, there's if you go down to the bottom, share screen, it should say stop share screen, or there should be a red.
There's a red one that I can't get to. There it is. I just saw it. Okay. Okay. Perfect. I'm done.
All right, Sean, you've got host duty, so I'll let you take it from here. Thank you.
All right, Craig, I'll do my best. Hopefully this is working.
I can hear you.
Let's see here. Can you see anything?
No.
Okay, hold on one second. So you're not getting any video?
No, I'm not seeing any.
All right. Screen. Security, live meeting.
Are you in the share screen? Did that come up then?
Yeah, hold on one second.
Okay.
Anything now, or is it still me?
It's still just you. Yeah.
Oh, wow. All right, because I have my PowerPoint pulled up.
Yeah. Did you share a screen? Then just give you the option to select that application.
Let's see. Here we go. Okay. Anything now?
No. We could, if you want, I could try to do it on mine, and you could speak, and I could do the, I could try to do the presentation for you.
This is so. Hold on one second. Let me just try one more thing.
Why don't we try that?
Okay, sure, because it's just, for whatever reason, I'm not able to pull it up.
Okay, I'm going to reclaim host duties then. And,
Okay.
let me see if I can share your presentation.
Okay, is this you, Greg?
Yeah, can you see it?
Yeah.
Okay. So I can go through if you want me to change them as needed. I can do that. So.
All right, yeah, let's move down to the second slide. Sorry about this, everybody. Obviously, having a little bit of technical difficulties, but thanks to Dr. Tovar, thanks for having me here. Just kind of wanted to go over how toxicology applies to the Wisconsin workers' compensation statutes. And I know some of you are in different states. I do think there should be some overlap here as we go through this. And there's two primary sections. 10258 sub 2 deals with intoxication and a complete denial of benefits with the exception of medical expenses. And then 10243 sub 9, when an injured worker is test positive and violates a policy for, okay. Hold on one second. There we go. Violates that policy during the healing period when they're otherwise released to work with restrictions. So let's move down to 10258, the third slide, Greg.
This one?
Down, let's go down. I'm still seeing that you're on slide 2.
Oh, sorry. There?
Yep. So 10258 sub 1, this deals with your traditional safety violation that we're really not going to get into. So let's move down to sub 2 on the next slide. All right, 10252, if an employee violates the employer's policy concerning employee drug or alcohol use and is injured, and if that violation is causal to the employee's injury, no compensation or death benefits shall be payable to the employee or a dependent. Now, I've italicized some of this statute just because there's been some recent state changes. Let's move down, Greg, to the next slide. This statute was enacted on March 2nd, 2016, and this basically was a huge change in our Wisconsin workers' comp law. We went from a 15% decrease in compensation when proved to 100% complete denial of compensation when these elements are proved, both I should say, primary compensation and death benefits. Before this date, there was only a possibility for a 15% decrease capped at 15 grand for those benefits. And we'll get into the April 29th changes that were just made. And again, that applies to that italicized language. We'll get to that in just a bit. Next slide, please. So as you can see, with 10258, sub 2, no indemnity is payable for primary compensation and death benefits. We're still on the risk for reasonable and necessary related medical expenses of treatment. That's 10242, office visits, appliances, mileage, costs of medicines, drug treatment, supplies, and training. Next slide. All right, so how do we establish this violation under 10252, I'm sorry, 10258 sub 2? First, the employer must have an established drug or alcohol policy. This should be in writing. It should be signed off on by the employee. It should be regularly enforced. This policy should be specific. And again, a lot of this relies upon the employer. We're going to be governed by the language within that policy, which we really don't have control over. But this drug policy from the employer should deal with timing, the types of testing, as you've heard from Dr. Tovar, multiple different types. What do we do with the samples, the storage? Are you entitled to a second drug test? All of those policies need to be spelled out. You also have to spell out what the resulting disciplinary actions are. Is it just a slap on the wrist, or is it automatic termination? In addition, what happens when the employee or injured worker refuses to provide a sample? Is that automatic evidence of intoxication, subject to automatic termination? You know, I mean, if that's the case, we could encounter problems at trial with a judge saying, well, you know, he just refused to take the test. That doesn't mean he was intoxicated. I mean, were that to happen, I would ask the judge to take an adverse inference simply because that claimant is the only one, you know, who could provide, you know, said evidence, and the fact that he's obstructing the process, I would think, you know, should weigh against them. But again, this all has to be down. It has to be written, you know, and like I said, even though there's no requirement in the statute that it's got to be in writing. I mean, if you have an established policy, why wouldn't it be? You know, that employee should have knowledge of it. Look to the hiring documents. That's usually, you know, they come in for to set up their when they're first hired, their W-2s, policies, whatever, that should be in there. And ideally they've signed off on it. Whether they've read it or not, who cares, as long as they've signed and dated it. And again, regularly enforced. Next slide, please. So the second requirement gets into establishing a violation of that policy. And as Dr. Tovar went over, this can be through blood, serum, hair, stool, saliva, many different ways, and we'll look to the policy to see how to do that. But you know, and you heard Dr. Tovar's definition as to establish intoxication. Not only do you need proof of the intoxication, but you also need observed behavior consistent with that intoxicating substance. And that's where, you know, it's really our job as adjusters to collect all the facts and witnesses. You've got to dig. Look to the physical data from the scene of the accident. Were there skid marks? Did they try to avoid the accident? You know, look to the vehicle itself. If we're talking a motor vehicle, were there any mechanical failures involved? Because you know darn well what you'll probably hear is, I don't know what happened, my steering wheel locked up. Oh wow, the brakes just went out. You'll hear all sorts of different things. Did anyone observe or speak with the claimant beforehand? Next slide, please. And continuing with that investigation, obviously, we'll want to get his or her medical records, lab records, prescription records. We need to know their height, weight, and again, we talked about behavior a little bit before and after. Ideally, it'd be nice to know when they last took whatever substance they took versus the time of the accident. Look to police records or video. Is there dash cam evidence? Did they have a camera on them? Is there body cam? Anything we can do to sort of help our toxicology expert link everything up. Now, it sounds like there's a different standard here between what a hospital might do if they're taken to a hospital immediately after an accident. I assume that if they're nonverbal, that might just be the hospital's, policies to take blood just to find out what's going on, what they can administer, what they can't. Otherwise, if the hospital doesn't do the testing, obviously we want to get that MRO, whether through a private company or not, to get those samples. And I would think the sooner the better. As they metabolize the substances, they should decrease. So the sooner after the accident, the better. I could also see, asking the hospital if it's there and not through a private company, to make sure they have, adequate chain of custodies, which it sounds like they do. And that they preserve the samples for future testing. None of that would hurt, and that's what helps to have a good nurse case manager or whoever it is that's been assigned, to this case right away. Next slide, please. Finally, after you've gathered all the evidence, you've got that existing employer drug policy, we need an expert opinion linking that intoxication to the injury. Without that, we don't have a case. So, I think that goes to what Dr. Tovar is saying as to what conclusions he can reach and what conclusions he can't reach. But the more information we have, the better. We have to show that the intoxication caused that injury. What I had heard in the advisory council, labor's big complaint is, yeah, so they're intoxicated, but what if the roof falls on them? That sort of thing. So that's where that causation requirement comes in. Next slide. Now, the prior language in 10258, back when it was only a 15% subject to a $15,000 cap, stated that if the injury resulted from the intoxication of the employee by alcoholic beverages or drugs, and that language varied, there's no specific causal language in there, but the courts required that causal connection, as you'll see in the next couple of cases. Yeah, next slide, please, Greg. And yeah, next slide, we can move forward. The first case, probably the most important one, is Massachusetts bonding. In this case, the worker was a cook. He was called in, he was being fired to pick up his supplies and last paycheck. Apparently he was missing work due to his excessive drinking. The head chef meets with him in the kitchen, gives him his knives, his salary. The guy signed his check over and got paid in cash. The head chef noticed that this guy's speech was off, as if he had been drinking, but he didn't really show any concern as to whether or not he was able to get in or out of the building, whether he was having any difficulty walking, whether or not he needed to call him a cab. He just said, that wasn't my business. I didn't pay attention to that. So after collecting his things and signing off, 15 to 20 minutes later, he's found at the bottom of the set of some basement stairs leading from the kitchen. He's unconscious. His supplies are scattered all over the stairs and the basement. Next slide. In this case, the commission denied the 15% decrease in compensation that the insurer was arguing for. Again, the only testimony was the head chef's subjective belief that the claimant was intoxicated, based upon that history of drinking and the altered speech. But he didn't have anything else. So, you know, it's just him presuming that he fell down the stairs because he's drunk, and that's not enough. There's no witnesses. So this is a failure in your burden of proof. And this case does, and others, show that the employer insurer, the one making the claim, has the burden of proof. We've got to prove that. Next slide. This was appealed all the way up to our Supreme Court, and the court affirmed the commission. Again, we've got the burden of proof. We're alleging this violation. We've got to prove it. Based on the record, you really couldn't even establish that the worker in this case was intoxicated, or that the injury resulted from the intoxication. And there's language that's in this case from the Supreme Court that anyone can fall down a set of stairs, whether they're intoxicated or not, similar to what Dr. Tovar said with the roofer. You know, I mean, yeah, maybe you're more likely to fall off a roof while intoxicated, but that's not proof. So next slide, please. Now, another case I wanted to discuss was Holler Beverage Corporation from 1970. This is a liquor salesman. He's a traveling employee. He's killed in a one-car accident in 1967. While driving, he crossed into the opposing lane of traffic and struck a bridge abutment. There were no witnesses to this. There was a blood sample at the funeral home. So I don't know how long it took to get to the funeral home. I'm assuming that at the time of death, the metabolism stops, but you know, that would be a question for the expert, sort of preserving whatever the alcohol percentage was in the blood at the time of the accident, or at the time of death, I should say. That testing revealed a 0.29% alcohol by weight. I don't know if that standard is still around or not. The insurer conceded the injury, but applied for the 15% decrease in compensation, arguing, well, look, here we have evidence of intoxication, and you know, he's on the opposite side of traffic. You know, I think that's enough. There's they also, next slide, please, pointed out that there was no mechanical malfunctions in the car that was being driven. The commission denied the application of the 15% decrease. They did agree that he was intoxicated. There was enough proof of that. They rejected the testimony of the bar customer, who also may have been the bartender, who said that, he looked fine. He wasn't drunk. But again, this is the second standard. You've got to prove causation. And the commission said that the employer insurer failed to prove that this accident was a result of that intoxication. There was no expert testimony linking the intoxication to the crash, and simply showing, the employer showing that there was nothing wrong with the car wasn't enough, and that got affirmed to the Supreme Court. Next slide. This other case, Olson, took place a little earlier in 1956. It's just an interesting case. The worker was a traveling employee, was sent to Wisconsin to purchase a load of corn in Minnesota. After taking care of business, getting everything done, loading up the corn, paying for it, it was around 7 p.m. And this worker and some of the elevator employees decided to go out and have some drinks. They testified, or he testified, that he only had beer. But that was disproven later. After a couple hours of drinking, the police chief of the town stepped into the establishment wearing his uniform. This worker, who had been drinking for several hours, turned to the bartender and said, "You either throw that officer out of here or I'm going to do it." So, you know, maybe evidence of a little bit of lack of inhibition, which I would think, or impulse control, which would, you know, be indicative of somebody who's enjoying their alcoholic beverages a little bit too much. Shortly after this, the police officer obviously stayed around. This worker and a local man get into a fight outside on the street. The officer breaks them up, and they then I guess gives them a warning, and then they start fighting again. At the second time, the police officer separates them and says, "You're under arrest." Next slide, please. I guess the local was a little bit more rowdy than our worker, so the police officer could only handle one at a time. He didn't have backup. He tells our worker, "Stay right there. You're under arrest. After I put him in jail, you're going." And surprise, surprise, when the police officer came back 10 minutes later, our worker was gone. Later that night, a county sheriff finds him 14 miles east, heading back towards Wisconsin, which incidentally is why this was a compensable claim. I mean, you'd think, drinking, being belligerent, fighting, ignoring a police officer would be a substantial enough deviation. However, because he had the dual purpose of going back home while being a traveling employee, that won out. Anyway, the sheriff finds the truck overturned, and he smells liquor, and this claimant severely injured. The physical evidence from the scene showed that this worker was driving on the left-hand shoulder for some distance before he struck a concrete spillway and crashed. Next slide, please. This time the commission does award the 15% decreased penalty to the employer. They relied upon the testimony from the two police officers as evidence of intoxication. And I do think evidence from a police officer is a little bit strong or better than a layperson. Obviously, police officers are trained in intoxication. They know how to identify it. So I think they can be, their testimony can be almost that of an expert versus a layperson. Interestingly, there were no studies done. Although taken to the hospital by the ambulance, there's no mention of any testing, alcohol or otherwise, with this. But they did establish the element of intoxication through those police officers. The commission then found the linking, remember, you have to link that intoxication to the injury, basically relying upon the physical evidence, that being he's driving on the wrong side of the highway for several miles, and clearly that is what caused the accident. Somebody who's sober probably wouldn't have been driving on not only the wrong side of the road, but the shoulder. And at that point, it was established that given certain circumstances, the commission can make reasonable inferences. That's not as to intoxication and the cause of the injury. Generally speaking, that's not something I would want to do. If we're taking something to hearing, why wouldn't we submit it to a toxicologist? Let's have them link it up. Let's not leave it up to the chance of the commission making a reasonable inference if we're going through all this trouble. To try it and it doesn't resolve. So, again, you want to give a judge as many reasons as possible to find for you. Next slide, please. Last one, Heritage Mutual. This is the Frozen Fingers case. 1996, the worker was traveling to his mobile home, doubled as a sales office in northern Wisconsin. He intended to make several sales calls in that area the following day. It's about a 150-mile drive. He gets there around 2:30, 3 o'clock, goes to a tavern, he testified that he had 4 to 5 Kessler and Diets over the course of a couple hours. Who knows how many he had. Around 6 o'clock, he heads to his mobile home. His intent was to make dinner, go over some paperwork, and then get out the next day to visit some clients. He ends up not being able to get into his mobile home. Apparently the lock was frozen, snow was blocking the door. He smashes a window. At some point during his exertions, he passes out. He spent the night in sub-zero temperatures. I think it got down to -25, had severe frostbite requiring the amputations of the fingers and thumbs of both hands. Next slide, please. The commission found the injury compensable as he was in the course and scope of his employment as a traveling employee because he had returned the deviation of the bar, he had returned back to his employment after once he was heading back to his mobile home. But they did agree to apply the 15% penalty. And by the way, the courts had upheld not only up to the Supreme Court, had upheld not only the finding of a work-related injury, but that the 15% decrease could not apply. So the Supreme Court then affirms the commission and says, no, the 15% penalty or decrease does apply. They could draw a reasonable inference, as they did in Olson. Clearly, there was evidence of intoxication. That was based on the hospital records of ethanol abuse within those records. And then they inferred that the intoxication was causal to the injury, as it was probable this worker remained asleep for such a long time due to that intoxication. And again, they also referenced the subsequent medical report, which stated loss of consciousness due to ethanol abuse. Next slide, please. So here we have these findings made in the absence of direct evidence. There wasn't any expert testimony. Apparently the worker had taken some diet pills, although it sounds like that's not really something that's going to affect the intoxication or in terms of affecting the alcohol, but who knows. There was no analysis of the effects of the alcohol on sleep, the interaction with the cold, time required to cause frostbite, and how the alcohol caused him to stay passed out longer than perhaps a normal individual would. No analysis regarding his weight. The time period with the 2 to 3 hours he consumed 4 or 5 Kessler and Cook diets, what his blood alcohol concentration would have been, all these circumstances. From the record, it sounds like he was an alcoholic. So, that wasn't factored in. Obviously, his tolerance levels would have been higher. So, but nevertheless, it was applied in this case. Next slide.
Hey, Sean, I just want to let you know we've got a couple of minutes before our regular stop time, but just wanted to make you aware of that.
Thank you, Greg. Trying to move it along. Interesting, getting back to the what I italicized under 10258 sub 2. The recent amendment of in this past April specifically exempted the Wisconsin Supplemental Injury Fund from death benefits. In a normal case, exclusive, if we're putting intoxication defenses aside, if there's a work injury and that causes injury, we pay death benefits. And those death benefits go to the dependents. You either have a total dependent, such as a spouse, kids under 18. They can be over 18 if they're developmentally disabled or whatnot. Those are total dependents. Otherwise, there's partial dependents. Maybe the injured worker was giving money to their elderly parents, or their adult children, such that they could qualify for partial dependents. If there's no dependents, and if there's a work injury that results in death, what happens is, the insurance company doesn't get off, get a bonus, get a freebie. Those death benefits, instead of going to that would have gone to the dependents, instead go to the state fund. So the state fund sort of sits in the shoes, even though it's not technically subrogation, it sits in the shoes of the dependents. And, it's a substantial amount of money for 2021. The death benefit, the max death benefit is just under $330,000. Next slide, please, Greg. So the state has taken the position that because the statute doesn't say, now says they don't get the death benefit, but because it didn't say it at the time, if a death occurs and there's no dependents, and of course we've met all of the elements of 10252, 10258 sub 2, that the fund gets these benefits, and that's going to apply from March 2 of 2016 to April 28th of 2021. Now, there's a case right now that's at the Court of Appeals arguing, no, that wasn't the intent of the legislature. And by the way, the legislature was going to pass this amendment, making it clear that the fund is not entitled to those death benefits last year. But it had to break up due to COVID. And then never got voted on. So it'll be interesting to see what the Court of Appeals says. And this case, next slide, please, is Diclo, and Paul Regal has it. I think there's a couple other cases out there. I don't know if they are as advanced, but the Diclo case, the claimant ran at the back of a school bus. Fortunately, none of the kids on board were injured. He was killed. He had no dependents. The employer had their drug policy written, claimant was aware of, he signed off on it. Full autopsy and toxicology report after the accident revealed the presence of cannabinoids, a cocaine metabolite, and ethanol at the time of the accident. A post-accident reconstruction revealed there was no effort whatsoever by him to stop. Again, no skid marks, no attempting to swerve, whatever. He didn't attempt to slow down. He just went right into that bus. Dr. Tovar actually performed an expert analysis in this case, and he conclusively linked the violation of the drug policy through intoxication of the claimant to his death. Next paragraph, or next slide.
Sure. Hey, Sean, I just want to say, since we did hit the noon mark, I'm going to let you finish at whatever speed you want. If people have to go, that's great. We're going to record this. I just want to thank everyone who is still on for attending, and like I said, hope to see you all soon, but continue, Sean.
Sure. And if anybody has any questions, obviously you've got my PowerPoint. Feel free to look at this. Maybe you've got the video. You can always send me an email or give me a call, and I'm happy to discuss any specific issues that you have. With this case in Diclo, like I said, it's currently pending at the Court of Appeals. Both the ALJ and the Commission found in favor of the fund that they're entitled to their $20,000 payment and the full death benefits. The Circuit Court actually reversed, so and said no. I mean, clearly the intent was to bar compensation and death benefits once you've established a violation of 102.58 sub 2. It makes no sense to deny widows and orphans, but then the state gets a chunk of that. So again, they sort of stand in their shoes, and if the widows and orphans aren't entitled to it, why would the state? I'm assuming we'll have that decision maybe by the end of the year, maybe early next year, and I would think the aggrieved party will most likely appeal to the Supreme Court. So that'll be pending. Moving on now to the next section, which is going to be takeaways. You must have that causal link. That's not a new thing. That's been present in the application of these cases for many, many years. New, of course, is that the employer must have a drug and alcohol policy. And like I said, we're going to be bound by what's in those policies. But once the ball is in our court, dig in, let's get the facts, and then establish those violations with expert opinions. Next slide. Returning to work with restrictions. Toxicology also comes in. Substance abuse comes into the law under 102.43 sub 9 after an injury. And it doesn't apply when they're 100% off of work. However, if they've been released to return to work with restrictions, then there's two subsections that we'll be dealing with. Next slide, please. And let's go to the next one too. The first one is when the employee's employment is suspended or terminated due to their violation of the employer's policy concerning employee drug use. And the italicized emphasis there is mine. And this, of course, is always during the period when they could have otherwise returned to work at light duty. And they added the requirements of, having an established policy in effect before the injury, and that it's in writing, regularly enforced. That way everybody has the has notice. Next slide. This subsection, sub C, went into effect on April 1st, 2006. If all conditions are satisfied, we don't have to pay TTD. We can deny that during the healing period. Again, only while on light duty. If 100% authorized off for work, it doesn't matter if they've been fired for intoxication violation of the policy. Again, in order to establish this, you need a written employer policy acknowledged by the worker. It's got to be in effect before the dates of the injury, regularly enforced, and you've got to show that violation of the policy resulting in the employee's inability to work. Next slide. Now, the problem with this is probably in the way it was drafted. The division construes this such that it rarely, if ever, applies, unfortunately. They maintain that the drug test has to come after the injury while the employee is on light duty. They want to see a second drug test. That's rarely done. Most employer policies only provide for a drug test at the time of the injury. If that test is positive, they fire the worker. And so why would we get another test down the road? The employment has already been terminated. If the test is negative, what reasonable cause do we have to get another test down the road? And that's, again, is getting to the employer's drug policy or alcohol policy. Ideally, there'd be a provision in there stating that not only at the time of injury, but when the worker returns to work at light duty or is able to return to work, whether at light duty or full duty, there's provisions in it such that they would have to get tested again. Additional testing is expensive as well. So, but to comply with this per the division, this circumstance encompasses this rule, law encompasses very limited circumstances and isn't often used. Next slide. I did find one case, alert case, and their reason for denying the application of the statute was that it said employee drug use. There was no mention of alcohol. If you recall the italicized language from above, we're dealing with employee drug use, and they pointed to, the other statutes, specifically 10258, which says both alcohol and drug use. In this case, Rudolfo Gomez, Mr. Gomez showed up to work drunk while he was supposed to be working light duty. There's no dispute as to this. And per their policy, the employer terminated him. And rightly so. But again, both the ALJ and the LERC said no. If the legislature had meant to include alcohol, they would have said it in this subsection, and they didn't. I do take issue with alcohol not being considered a drug. I would think most physicians would agree that alcohol is a drug. Just grabbing a general definition of drug online, it's any substance which has a physiological effect when ingested or otherwise introduced to the body. Clearly, alcohol is a depressant. Too much of it will lead to death and shut down your central nervous system. And if you don't like that definition, why not look to the Workers' Compensation Act for the definition of a drug? 102.425, dealing with the drug, prescription drugs and non-prescription drug treatment, defines drug under sub C, and it points us to section 450.01 sub 10, which basically mirrors the federal definition of drug, which is quite expansive. And I do think alcohol would qualify as a drug through that. So there's another way to look at this too, should this circumstance ever arise. Next slide, please. The last one, probably the most used over the past couple of years, is 102.43 sub 9 sub E. When your worker has been terminated, suspended or terminated due to misconduct under the unemployment statutes or substantial fault connected with their work. Now, we're going to deal with misconduct. Next slide, please. This statute went into effect on March 2nd, 2016, And, you know, like I said, while, again, this is all while you're released to work, light duty, temporary restrictions, is the only time it'll apply. If you can establish misconduct under the employment statute, which is 10804 sub 5, you know, we can deny benefits for intoxication. And let's go forward. There's a general definition of misconduct that was taken from the old Boynton cab case. But what we want is a subsection after that. Next slide. And here we have the subsection specifically dealing with the employer's reasonable written policy concerning the use of alcoholic beverages or drug use. You have to establish the employee had knowledge of that policy, and you either need the employee to admit a violation, they can refuse to take a test or test positive, and that test has to be in accordance with a testing methodology approved by the department. I haven't found exactly what that methodology would be, but I'm assuming if you're going to an expert toxicologist, anything that's reasonably medically acceptable, you know, would probably suffice. Next slide. So again, similar requirements. You need that established drug or alcohol policy, must be in writing, preferably signed off to show that the employee had knowledge of that policy. It's got to be regularly enforced. Otherwise, an ALJ could find it unreasonable. And as we went through the statute, sometimes you can just get the injured worker to admit it. When you find them in the employee changing room, you know, passed out and they're reeking of alcohol, you know, usually they'll admit that. If the injured worker refuses to take a test, that can be evidence of a violation as well. And I would look to that employer drug and alcohol policy as well to ensure, you know, that. Situations where we, you know, may need a toxicologist again is making sure that our testing methods are accurate and definitive. Next slide. That's all I have. So hopefully that's instructive and you know, helpful to you guys. And you know, it was great to hear Dr. Tovar and get a little bit more in depth on this.
Well, thanks, Sean. I want to thank Dr. Tovar as well, and those of you who stuck around. I can't see the chat from my perspective, so I don't know if there's any questions. If you guys can see the chat area, I'm going to stop my sharing of the screen, but it looks like there aren't any new questions. So again, appreciate everyone's time. If anyone has any questions, you can reach out to me or Sean Spencer directly, and wish you all a great day. Go Bucks.
Thank you, Craig.
All right.
Thanks,
bye.
guys.
Thank you.
Thanks, Dr. Tovar.
Thank you.